Hi, good afternoon. Welcome to this afternoon's webinar from Surgical Holdings. Today we're looking at an overview of flexible endoscopy, and I'm joined by my colleague Nick Williams, who's going to be presenting this for us. Welcome, Nick. Thank you for joining us. So this is the third in the webinar series that we're running. We've run so far this year. So first of all, we looked at back to basic on surgical instruments. Then we had an introduction to rigid endoscopy. And this is the third session. There will be others which we'll be introducing in coming months. Just a couple of notes. So obviously, as we go through, if you have any questions, if you want to stick them on the Q&A or the chat, I'll keep an eye on both because quite often people will stick them on the chat rather than the Q&A, which is fine. Certification wise, the certificates after the webinar, I will send off attendees information to CPD, and CPD will then raise the certificates and you'll get them from them directly. So you will get a follow-up email from us, which you'll be able to rewatch the webinar if you need to. So you'll have all access to that, but please be patient on the certificates because CPD can take a little while to send these through, but they will come through. Final point is, I think a couple of people have been asking me about slides for previous webinars and being able to access those. And I'm going to share access to these in the follow-up email, maybe this follow-up email or the next one, so you can log in and you can get access to all of those. So that will hopefully be of use. But yeah, as I say, if anything comes up, please chuck it in the chat, and we will try to address all the questions we can. So without further ado, thank you very much. I'll pass you over to Mr. Williams.
Thank you, Mr. Cool. Right, good afternoon and welcome to this overview of flexible endoscopy. Really, it's a basic review looking at the anatomy of a flexible endoscope, both internal and external, looking at some of the design sort of issues in terms of the compromises that design engineers have to do with flexible endoscopes, looking at how some of the instruments are used in a number of procedures, and then looking a little bit about the damage that can happen to them. So first, very basic aspect, endoscopy. What is it? Oscopy is to look, and endo, look into. So an endoscopy is to look inside using an endoscope. There are two basic types of endoscope. I've been in the industry for too many years, and so many years ago it was pretty black and white. It's not so black and white now. There's a flexible instrument that's put into God-made openings. That's not a religious statement. If you're an atheist, then natural orifice will do. Rigid instruments are generally put into man-made openings, but there are some exceptions to the two of them. As I was saying, years ago, it was quite a black and white situation. And there was a basic flexible instrument and a basic rigid instrument. The flexibles were diagnostic, really, and the rigids were more therapeutic. The flexibles were used in an endo unit, and the rigids were used in theatre. So it was black and white, but it's now grey. And if we go to black and white, and I'll just use the pointer here this is a basic fibre optic instrument. You can see it's fibre optic because it's got an eyepiece there, in the same way there's an eyepiece there. So that was a very basic diagnostic flexible instrument. And this was a therapeutic instrument. This is actually a resectoscope, which is used for transurethral resection, either of the prostate or the bladder. You've got a telescope inside, then a number of sheaths. Probably too small to, but at the tip there is a little loop for an energy, using energy to resect the prostate or the bladder tumor, and a working element here, which is the handle. So it was very much a case of therapeutic or diagnostic. You've now got something like this. This is effectively a telescope with a flexible tip for use in laparoscopic surgery. So that can be angled. You could go beyond the area of interest and look back on it, for example. And then you've also got the developments in the flexible area. This actually was a slide that came from, I was in the States a number of years ago, and there was natural orifice surgery taking off at the time. And this was illustrating trying to take out the gallbladder through the mouth. Didn't completely take off because of the limitations of the outer diameter of the scope, but still it was quite an interesting development, and there's certainly been a lot of development on using flexible instrumentation for therapeutic procedures. So let's look at the scope. Well, first of all, sorry, I should say endoscopic instrumentation. There's lots of other sides to it. I'm going to talk about the instruments in a minute, but there are video systems. This is a good example of excuse me, that's a fiber optic instrument. You can see there's an eyepiece there. That's a video instrument. You see there's no eyepiece. There's some buttons on the top. Video systems are used to either put a camera on the top of there or take the image back from the chip. There's endoscopic ultrasound. This is an example of an endoscopic ultrasound picture, which is the 2D black and white ultrasound into the body through that. I'll talk about that shortly. There's magnetic imaging. This is an example of a colonoscope with a magnetic insertion tube, where you can actually see how the scope is looping in the body, which aids getting rid of the loops. There are flexible accessories. There's been a lot of development in the accessories. These are the devices that go through the channel of the instrument and can either do diagnostic things such as taking biopsies, or therapeutic, such as grabbing stones, smashing stones, stenting, etc., etc. There are also energy devices. There's been a lot of development in the energy world in terms of what you can, how you can use energy through instrumentation, and then obviously, very importantly, there's cleaning and disinfection systems. So, lots of areas that we could talk about, but we're only going to talk about one, which is that. So, basic construction of a flexible endoscope: 3 sections. The handpiece, obviously, not surprisingly, where you hold it, or it's termed the control body, the insertion tube, and the umbilical, which goes to the light source or the video processor. In some countries, that's called universal, so you may have heard of that as a universal rather than umbilical. Obviously, you have to have an optical system in there, otherwise to be pretty useless. That's either fiber optic, so there are some instruments, as I've already highlighted, that have fiber optic imaging bundles in them to get the image back from the area of interest, or you have a chip on the tip of the instrument and effectively a camera right at the tip of the instrument to get the video, get the imaging back. Because the area you're looking at is where the sun doesn't shine, you need light there, and that comes via fiber optics, or 2 headlights, if you like, usually. So you need to take the light down. And there's a flexible bending section at the tip of these instruments, so you therefore need angulation wires to move that. It's usually like something like that, either in 2-way or 4-way, so either up, down, left, right, or with smaller instruments, just up, down. And then you have channel systems. There's air channel, water channel, suction biopsy channel, and there can be additional channels. In some instruments have auxiliary channels, and then therapeutic instruments, such as therapeutic duodenoscopes, have what's known as a rager bridge or an elevator bridge, and I'll come back to that in a minute. And there's a channel with a wire going down it to move that up and down. I'm talking about the anatomy of the instrument. So this is the outer anatomy, if you like. I'll talk about the inner anatomy next. This is a very diagrammatic picture of a flexible instrument, starting at the distal tip and working backwards. This is the bending section, so that goes in up, down, left, right, coming back through the insertion tube, and then you get into the control body here. This particular example has a tube stiffness control here. So there is actually a mistake on this diagram in that implies that it's a colonoscope, and as you can see, that's not a particularly long insertion tube for a colonoscope, so it'll be a colonoscope for a very small person. Biopsy valves, and then you've got the wheels here that control the left, right, up, down angulation. And there's also a mistake there, that's up, down rather than left, right, and up, sorry, so not both right, left. And so 2 mistakes on this lovely thing, but I thought it's quite useful because it shows the thing overall in a diagrammatic way. Then you have remote switches on the top. These are usually used for freezing the image or taking an image, or maybe a change in modality. They're user programmable. And then you've got 2 valves, suction valve and the air water valve here. So that the operator will hold the hand around here and use fingers for the suction and air water. And also, so it's usually left hand on here, left hand fingers using there, and then right hand using the left right up down angulation. And then moving back towards the light source, this is so that's the deliberate example that actually should have been on there, not there. This then goes back to the light source, light guide connector here, and then the connection to the video processor here, and then air water. So that's the outer anatomy. As you can see, quite complicated design, and these are very complicated internally. And that's an example of the internal structure. So moving from the outside in, there's a polymer, and then following a stainless steel mesh and some inner bands. And those bands are actually very sophisticated and had a lot of development behind them. I actually got many years involved with the development of the adjustable stiffness scope in this country. And I think from start to finish, that took about 12 years, I think. So although these look fairly basic, there's been a lot of development in them. Moving inside, you can see a lot of different channels. Going through those as we go, there's a forward water jet channel that actually goes to wash the lens in colonoscopes, a water channel, an air channel, and a biopsy channel. You obviously need to get the light down, so there's a light guide that takes the light down and then the image back, in this case via a chip. So the chip is at the tip, and then the CCD wires taking the signal back to the video processor. And then you have angulation wires, and in this case 4. So you've got 4 up, down, left, right. And so as you can see from that, things are pretty tightly packed into an average instrument, and there's a lot of technology in there, and I think generally you'll find that flexible instruments are really at the sort of the edge of the state of the art in terms of what you can squeeze into any given outer diameter. Internally, this is just again diagrammatic. Internally, there's a number of channels, and this just shows you how they're designed and go through. So from the tip here back, suction will go through there to the suction connection, air water again back into the air pump or the water pump, and obviously that all of those channels need to be brushed, cleaned, flushed, etc. And that's the most basic scope. That's not showing you additional auxiliary channels or razor brig channel. So you can see it's really quite certainly state of the art and complicated in terms of the internal external design. So let's look at the design criteria. As I've already indicated, the overall issue when designing endoscope is the outer diameter, how big, because obviously the bigger it is, the better in terms of the designer, but not so good for the patient. Clearly, if you wanted to design a flexible cystoscope, for example, you can't have a massive outer diameter. It may give you fantastic images, but you won't get it in. So the compromises are really in terms of a given outer diameter, what field of view, direction of view do you want, how much light do you want, type of light, type of imaging, what do you want in terms of diagnostic or therapeutic. Just to explain the type of imaging, excuse me, that's standard white light, what's termed as white light imaging. There can be other types of imaging depending on the manufacturer and the supplier and what they're doing. That's called narrow band imaging in this case, and that's autofluorescence, but there's a number of different types of imaging. But the biggest one is really, what are you going to use it for? And is it primarily going to be a diagnostic instrument, in which case you want focus on optics, and a channel for biopsy, or therapeutic, in terms of you might want one channel, you may want two channels for therapy. Excuse me. And then obviously cleanability. Very important in terms of the design is it has to be cleanable, and it has to be serviceable. These are not inexpensive instruments. I mean, state-of-the-art colonoscope nowadays is as much as quite a nice car, and you're looking at a life probably in this country between 10 to 15 years. And so clearly the life cost is dependent not only on the initial capital cost, but also on the revenue over those 10 to 15 years. And if its serviceability is poor and it's very expensive to service, then that's clearly a major factor in the life cost. Overall price is always one of the biggest issues. So a lot of issues for the budding endoscope development engineer. That is a head-on diagram of showing you the problems that you've got in terms of what balance do you want, and if you increase the instrument channel, let's say you have two channels, that it reduces significantly the area that you can use for imaging, for example. And to give an example with that, that's actually a twin channel scope that you can see very clearly, two channels, which obviously means there's less room for the headlights here, which is the light coming down and the optics taking it back. This is a side viewing scope. So this is a duodenoscope, which is used for ERCP, which I'll explain shortly. This has a razor bridge, so the optical area here is looking sideways, and as you can see, there's a lot of that design taken up with the accessory channel, and the guide wire, for example, in that case is moved through there, and that is then moved by the razor bridge here. Another example where of a scope where actually there's a big amount. This is the optical aspect, and that's the channel side. And you can see here, probably some of you are wondering what the hell that is. That is a curvilinear transducer for ultrasonic transducer attached to the instrument. So that's sending out ultrasound in that plane, and you then use what's known as FNA, fine needle aspiration, so effectively a biopsy needle that comes through there, and you look at it in real time in the tissues to see where you are to take your sample from the right area. So again, very complicated scopes and potentially very expensive if you damage them. This is actually it was a prototype, but I've kept the picture because I thought it was very useful in terms of showing some of the innovation that can be done with these instruments. And certainly as therapy is done more and more, I hope we'll start seeing more of this type of design. I think it's very elegant. And as you can see, the whole thing closes down. It gives you two channels here coming out, which gives a better surgical angulation to come in. This has a grasper and then a hook. It's got another channel you could use, for example, a laser fiber, and this is the area that's devoted to the optics. That was developed but never really sold, but it was developed really for natural orifice surgery I alluded to earlier. But certainly with something like that, I think that could be very interesting to how things are developed in the future. So that's giving you a bit of a side to the sort of the anatomy of the scope. Let's look at how the scopes are actually used. So I've listed a number of oscopies there, which I think using flexibles. I'm sure there are a few more weird and wonderfuls but those are the main ones. So GI is the biggest area for flexible endoscopy. So upper GI or lower GI, gastroscopy or colonoscopy, ERCP, which I'll come back to, endoscopic ultrasound, enteroscopy, which is small bowel endoscopy, and then bronchoscopy for the lung, cystoscopy. So in the same way you've got upper and lower tract here, you've got upper and lower tract in the urology or urogenital tract. ENT, so rhinolaryngoscopy, hysteroscopy, and also with anaesthetists for difficult intubation. So instruments that are used for getting helping out with difficult intubation for in anaesthetics prior to operation. Let's look at some of those. So one of the very basic, simple, says what it does on the tin. So gastroscopy goes into the stomach. So very simple intubation of the scope in through the esophagus. Sorry, that's an American spelling of esophagus, and into the stomach. They'll usually do the first part of the duodenum as well, and that's an example of a through the scope view with an ulcer. So very common procedure, as are the lower tract. That's a view of the colon through a scope. And I think this is a good example. I've used this slide as an example because of how flexible endoscopy has moved from diagnostic to therapeutic. I mean, when I first started many, many years ago, colonoscopy was principally a diagnostic tool, some biopsies, and that was about it. But with the likes of colorectal cancer, I mean, in this country, we have a colorectal cancer screening program. So you may be an asymptomatic patient who goes to a colonoscopy and you pick up an early cancer, which is the whole point behind it. Let's say it's an early cancer. I mean, there is potential with the technology that we have now to have a look at it, potentially stage it with an endoscopic ultrasound, so you see how far into the wall it goes, and then take it out through the scope. That is done via a process called EMR, endoscopic mucosal resection, and the technique is to inject fluid with a dye, so you can see the fluid, to lift the area that you want to resect. You basically lift it and then snare it and then remove it. That's an example of a through the scope image, and you can see the dye has come in as it separates. This is obviously the area that needs to be taken out, and you snare it and then grasp it and take it out, and that's what's left, which looks pretty horrendous, but don't forget this is very highly magnified. And the beauty of this is you get it early, and with colorectal cancer, the great thing about getting it early is it's a cure. So that's a good example of how what a diagnostic technique has really now become therapeutic, and almost it's a one-stop shop in that case. Moving on, ERCP I mentioned earlier. ERCP is an abbreviation which stands for endoscopic retrograde cholangiopancreatography, which I'll explain in more detail in a minute. But it's using that side viewing scope that I showed earlier. So it's intubated, it's put in through the mouth into the stomach, and then first part of the duodenum, and it looks at the C and the P. C and the P is for cholangiopancreatography. So cholangio is to do with the biliary system, pancreas is to do with the pancreas, which isn't actually here, but the pancreas comes out here. And both the pancreas, you can see there's a little join of the duct there. Duct from the pancreas, duct from the biliary system come out into through the what's known as the ampulla of Vater, into the to help with digestion. And really, that's another example of, I mean, certainly companies used to have diagnostic duodenoscopes and therapeutic duodenoscopes, therapeutic being much bigger. And now I think, I would imagine there's hardly any diagnostic scope sold. It's almost always sold a therapeutic scope. So again, illustrative of how that procedure is as more and more therapy is done through the scope. That's an example which I explain in terms of the ERCP. Endoscopic retrograde, looking back. So it's through an endoscope, it's looking back. Cholangio is the biliary system here, and pancreas is the pancreas, and ography, fluoroscopy. So that's through the scope image, and that is using the fluoroscopy. And you can see there's a little line there, which will be your, you introduce contrast in, and you can see this area is all expanded, and it's like a sort of a tree, that's the biliary tree, and with a stone here, it's blocked the flow of the bile back, and you then get jaundice and everything blows up. So, sorry, the biliary system blows up. So you can, by using therapy in that, you will then get rid of the stone, pull the stone out, and the biliary system flows. In terms of EUS, sorry, the bile flows through the biliary system. In terms of EUS, that was the other scope that I showed earlier. So you've got a curvilinear transducer at the tip of the instrument, and a needle channel. And as you're scanning in that plane, the needle, you can see where the needle goes. And these are pictures of that. So the area you're looking at here, you can see it's a different view on the ultrasound image. And that is the needle going in. Oops, sorry. That is the needle in there, and you take your cells there, and you know where you're coming from, send it off to pathology, and very targeted diagnostic biopsy. So, excuse my cough. My voice seems to be getting worse. In terms of other areas, so that's really reviewing the sort of the GI, which is the meat of the flexible endoscopic procedures. Another area there's a lot of procedures is in the urological tract, cystoscopy and uterinooscopy, so ureter and renal kidney. Again, it's upper tract and lower tract. So, and to use an example, upper tract. So you take the scope in, goes up into the ureter, and quite often a similar thing to what I was describing with the ERCP situation. You get a stone goes down, blocks that, and it blocks the flow of the urine. The kidney blows up, which similar to the biliary system blowing up as you saw previously, and that's then was termed hydronephrosis. So what you need to then do is get the stone out and let the urine drain. That's again a fluoroscopic view, very similar. You see the stone. That's the stone on the endoscopic view, and you go in and use a lithotripter, a mechanical lithotripter, or a laser, break it up, and then take out using retrieval devices, baskets, take out all the stones, and you end up left with a very nice ureter, and the urine can flow. Bronchoscopy, there is an increasing amount of therapy done through bronchoscopes, but in general, they're still basic, more of a diagnostic procedure. That's an example of a tumor, and these are the images that you can see. You get very high definition images, and going further towards the periphery of the lung now as technology is advancing. So that's a very brief review of some of the procedures to give you a feel for where these scopes are used. I've already highlighted they're expensive, and I've already highlighted that damage can be expensive. So we just talk a little bit about damage that can occur. I think it's pretty straightforward that because they're mechanical instruments, you can damage them mechanically. That can be through shock. One of the things you must be aware of whenever you handle an instrument is to not let the tip swing. Handle it, if for example, in one hand, if you're handling the control body there, handle bring up the tip and hold it with the same hand usually. Because if the tip is swinging and it hits something, it's very sensitive and damage there. It could be how you store it, trapping it in some kind of case. And then it's also can be damaged through the inside out through therapeutic devices. An easy, simple example is a laser. If you're putting a laser into a scope and the distal tip of that scope is bent something like that, and the laser fiber is quite sharp, as you're pushing it down, it can potentially pierce that channel. Then next time you process it, you can get fluid in, and if that fluid then gets to the chip, that can cause some problems. So it's external and internal potentially, but there's a lot of things that you can do to it. But you can also do things with the chemicals, what chemicals you use. There are disinfectants, there are detergents. The disinfectants I have the most sympathy with because they obviously need to kill the bugs and quickly, but they can't harm humans and they can't harm the materials in the scopes. And that's not an easy thing to design. Because any sort of damage to the insertion tube, you can get, for example, stickiness. And I'm sure some of you who've been in the industry for quite a long time will remember some certain chemicals that came out years ago and caused a lot of stickiness to the instruments, but very good at killing bugs. So it's another example of a balance and compromises. And obviously you don't want to get a chemical that then causes sensitization to the users. I mentioned autoclavable and single patient use technology. There is that out there. I mean, certainly I know of autoclavable technology in some of the organizations that I've dealt with in the past. I don't think there's any autoclavable scopes actually on the market at the moment, but the technology is certainly there, but it's expensive. And obviously you have to look at what is the return on investment on that expense. And then there's also single patient use. There's disposable technology out there as well. And there are pros and cons of everything. But there are significant cost implications on a lot of this. And we're really talking the majority of procedures are done with multi-patient use scopes. And obviously to get the imaging of a multi-patient use scope into a single patient use scope is another difficult one for designers. But in terms of the standard sort of instrumentation that is used on many patients, the thing to avoid is fluid ingress. And that is because, to use that slide again, it's very complicated inside. And if you get fluid inside that area, it can cause a lot of damage, particularly if you get fluid ingress into, so it hits the electronic side of things on either the CCD or the wiring. So if you put I used an example of a laser fiber. If you put a laser fiber through there and it hits that, and the fluid gets into that area of the scope and that channel, that can cause significant problems. So to summarize, they're high tech, they're complex, as I say. I mean, really, they're the state of the art in terms of a given outer diameter, what you can get in there. They're optical and they're mechanical. The mechanical side, for example, in a colonoscope is just as important. If the handling characteristics aren't good enough, you can't. An operator can't get the head of the instrument round to the area of the colon that he or she wants to. That's not really worth having very good optics if you can't get the distal tip of the instrument round there. The cleaning is not nearly as simple as cleaning rigid instrumentation. You've got internal channels and lots of other potential things like auxiliary channels and razor bridge channels. These instruments are a lot more expensive than rigid instruments, both in terms of initial cost and life cost. And care and maintenance is therefore important because they're all breakable. You'll cause damage. It's just a question of when and how much. But in terms of how much, what you want to avoid to keep bashing that drum is fluid ingress, because minor repairs, say a bending section rubber replacement, is I don't know the exact cost. It depends on your repair provider and the scope you're using, but it's hundreds. Major repairs is thousands. So I mean, if you're getting let's say a scope for, let's say 30,000 on as a taking a figure out of the air, if you get a £10,000 repair on that scope every year, then you can see the life cost, for say a 10-year life cost, is significantly affected by the repair revenue cost. So really it's down to sort of preventing those and definitely use your endoscope supplier and your repair provider, if you have a separate one, for care and maintenance training, because they will have teams to help you with this. I mean, the company I used to work for had a couple of teams that would that you could definitely use for this sort of thing, and they'll help you with how to clean it properly. I mean, it's on the web anyway, but they can do face-to-face training and in terms of how to clean it properly and how to do the best care and maintenance, and work with that supplier in terms of reviewing your repairs. And so if you see, I mean, definitely have regular meetings with them in terms of see if there are any trends that are happening. So if all of a sudden you start seeing a lot of distal tip damage, for example, it may be a new person in your department who hasn't had the training or doesn't quite realize how delicate the distal tip is, and they're running around with it, bashing around on everything. Simple things like that you can start looking at and nip those problems in the bud before they turn into very, very big ramifications from a repair spend perspective. And my last point is really intellectual solve problems, but geniuses prevent them. You may not get thanked for all the problems that you've prevented, but it will make a big difference to the overall budget for your department. And that's it. Thanks very much.
Great. Thank you, Nick. That's extremely insightful and some really interesting points to see that certainly I've made a few notes along the way that bits that I wanted a bit of further information on. But if anybody has any other questions, please stick them in the chat and the Q&A, and I'll jump on. Thank you for the various applause emojis that are coming through. So much, I'm sure Nick's very appreciative of that. Just a quick question from me. So on the scope internals, it's quite mind blowing when you see what is in that, and what sort of diameters are we talking there? So it's a few millimeter, right?
Yeah,
5, 10 mil,
10. 10. But I mean, some of them can get quite big. I mean, your channel sizes are usually about 2.8, 3.2 over an overall, 10, 11, 12. It really depends on what you're looking at. I mean, obviously that really weird scope that I showed, which is I thought a really elegant and interesting design. Obviously, those are getting bigger, and there's certainly a lot of development in that area. I mean, the term that I always used to hear was full thickness repair, full thickness resection in terms of repairing, taking out cancer from colorectal surgeons, for example. And I think you're going to have to sort of increase the diameter to start to get that, because you really want that angulation that was shown there to start doing that sort of thing. But again, I mean, to use the colorectal cancer as a good example, if you can do a one-stop shop and you literally are stopping that person, they're in this country, as I say, we've got this colorectal cancer screening program, and they go in asymptomatic, and you basically cured them of cancer that would have caused a huge problem. You've saved their life.
Yeah. Fantastic. And on the light guides, you mentioned like the headlights. Is that sort of the similar fiber optics to those you would see in a rigid scope? So
yeah, there's two same with them rigid scopes, but there's two types of fiber bundle. It's called a coherent fiber bundle for the imaging, where your top, all the fibers are stacked, so they're sort of stacked in that sort of way. So the top left is the same top left fiber at the bottom as it is at the top. So you basically build up a picture that way. And then you don't, that's obviously expensive to actually produce. And for light, you don't really care. So you just have an incoherent fiber bundle that takes it down. And that is the same fiber bundle that you use in rigid instruments.
Okay. Thank you. We've got a question come through, but it also ties into one of my other queries, was just around, I'd heard this term razor bridge a lot, and assumed it was RAZOR rather than razor as in raising the bridge, which seems more logical, of course. But that actual sort of component is mentioned quite a lot, and obviously, some of the conferences we've attended, Stephen's actually put a question around, is it possible, can you expand on that at all? The elevator channel, what is it and what it does? And I mean, there are you hear difficulties mentioned around cleaning that. I won't sort of tie you down on that one, but if there's any slight advice or info you can give on that, would be good.
I mean, the advice is to clearly, frankly, just get your local guy or girl in, because these sort of the first thing really is the razor bridge. I'm just trying to sort of do it in front of the camera, so literally does that. So that the sort of the accessory comes in like that, and then you move it like that. So you can then, to use the ERCP as an example, you can then guide that guide wire for what in the first term, or catheter or whatever you're using, or stent, etc. And just by doing that, but that channel, obviously, in order to do that, you need to have a wire to move the razor bridge, and that channel is a separate channel with a wire running down, so that has to be flushed and cleaned, and that's obviously essential. So getting to that, different manufacturers do it in different ways, and I'm not going to say, some companies will say this is the way to do it, and other companies will say that's the way to do it. So depending on the manufacturer that you use, I'd get them in and just get more information on that, and how making sure that you're cleaning it and flushing it properly. I mean, many years ago there were some cleaning machines that didn't actually flush it.
And is that because the technology moves on and perhaps some of the cleaning technologies don't, or is it education and just improving education around that?
That was a case which, I mean, as I say, many years ago. I'm sure that's not the case now, but yes, it's again, it's a problem in terms of the endoscope manufacturer and the cleaning and disinfection side of things is not the same manufacturer quite often. I mean, most endoscope manufacturers, I think, have their own cleaning devices, but there are other cleaning machines out there, and clearly, they both have to do the job properly.
Yeah. And obviously, rigid scope's been around a long time. When was the sort of first? When did these sort of first iterations of these scopes come onto the market? So are they? Because obviously, rigid scopes are sort of 40 odd years old, and were there rigid versions of these initially, or similar sort of things, or how did that emerge? I'm not assuming that you're old enough to remember like the first one.
Yeah, but thanks for the hint. Yeah, I mean, the truth is, I mean, the rigid side of things was donkeys years ago. Where you'd stick something through a natural orifice in, and try and get some light down there and have a look, and and there was used, there would be rigid sort of instrumentation used, upper GI, and they would use sword swallowers to sort of have a look. But the main way that the main stimulus for this in terms of development was actually Japanese gastric cancer many years ago, and the first developments were what term a gastrocamera, which is basically a camera, which you literally swallowed, and you had a sort of camera with a lens at the bottom that took the pictures. And that then developed into using the fiber optic technology to get the image back from that, and then onto video. So it evolved in a series of steps. Gastro camera, I don't know, 60s maybe. I was thought.
Right, wow.
I know.
Yeah.
Something like that.
So you mentioned like advances in the technology and the core. I'm going to say the coil inside, the protective coil, and the materials that are used there, and that taking quite a period of time. I mean, obviously we've got a different regulatory environment now, haven't we? So, would you envisage that this sort of thing to develop the next developments and technological advances with these sort of products are going to take a lot longer, but because of how tricky the regulatory system is now?
And that's a general point. I mean, I should highlight that Surgical Holdings, we don't do any flexible instrumentation. This is just purely from an educational perspective. But that's the same with anything. I mean, and again, talking about compromises in terms of design, this is another compromise that the regulations, the QARA stuff is there to protect patients ultimately, but the other side of it is, as that evolves and will have ramifications in terms of development. I mean, I mentioned, the variable stiffness, I think, took 12 years. That I would imagine will take a lot longer now, because the regulatory framework that you have to go to and hurdles you have to get over are more. And I'm not saying that's right or wrong, because that's quite controversial, obviously. But I mean, what's happening with the NDR is another example of that. I think, the practicality of that is, I'm sure that's the ethics of it and the aims are correct, but the practicalities are, you'll probably find that smaller manufacturers will pull out the market.
Yeah, certainly more challenging. That's for sure, and I suppose means that people with innovations will have a lot more consideration before they're able to start, looking at a timeline to getting stuff on the market. Certainly when I look back 20 odd years ago, when we were bringing out products or trying to develop products, it was a lot more straightforward situation to, if a surgeon came to you with a device, to actually get that manufactured and get it out there. But yeah, of course, our awareness
it's difficult from the development perspective, because you have an eloquent customer who will give you a very good reason as to why the sky is blue in this particular example, and then someone else will give you a very good reason as to why the sky is pink, and you have to then decide yourself as to which line you go down from a development perspective.
Okay, great. Well, if anyone has any other questions, I think I don't think there are on the other channel. Let's have a look. No, that's great. Thank you, Nick. That's very helpful, and I've exhausted my questions now. So I think we're ready to close up. But yeah, thanks to everyone for attending and taking interest in the webinar series that we're running. Thanks to Nick for his input here. Very, very interesting. And if you have any other questions, you can drop us a line. Oh, sorry, somebody has actually. Oh no, just a couple of comments coming through, but no further questions. So thank you, everyone. Have a good afternoon, and we will, as I say, the certificates will be coming through, and further details around upcoming webinars will also come through. But if you want to drop me a line, please do. Thanks, Nick.
Thank you.
Cheers. Thank you, everyone. Bye. Bye.